So good morning, everyone. If we want to resume our seats for the last plenary of today, we can get started. Fantastic. So I'm Mark Marzinki. I'm the co-PI of the HPTN Laboratory Center, and we're really enthused today to highlight some innovative work from the LC that obviously relates to both existing and future protocols. And I'm delighted to have, a panel of presenters that, are close friends and colleagues all based at Hopkins. So our first presenter today is Bill Clark. So Bill Clark is a professor of pathology at Hopkins. He's also the vice chair of pathology for quality and regulatory affairs and the director for clinical toxicology and point of care testing at the Johns Hopkins Hospital. Dr. Clark has published over 200 peer-reviewed manuscripts or book chapters and is the co-editor of the Contemporary Practice in Clinical Chemistry and editor-in-chief of the journal Clinical Chemica Acta. And today he's going to talk about targeted LC high-resolution mass spec with library matching for toxicology screening. Turn it off to Bill.
Great. Thank you, Mark. So this morning I'm going to give just a brief introduction to how we use targeted high-resolution mass spectrometry for toxicology screening. Before we get started, I do need to give these disclosures. The most pertinent one is the one from Thermo Fisher Scientific, as I consult with them and we do have a research relationship, and I'll touch on some of their equipment here. So in terms of highlights, we're going to talk about what exactly we mean by use of high-resolution accurate mass spectrometry for the screening. What we'll really take away from this is why we need to use mass spectrometry in the first place, how this technology helps us, and then how the technology helps us identify specific patterns of use moving forward in clinical use as well as the HPTN studies. So we want to really get started here talking a little bit about what are some of the challenges in the toxicology screening and how mass spec finds that. And we talk about challenges really because a lot of the toxicology screening we do in the clinic or at the trial sites is by using immunoassay. And these immunoassays for toxicology are typically class specific rather than compound specific, right? So if we have an opiate assay, what we're really picking up is codeine, morphine, heroin, hydrocodone, and hydromorphone. All of those can cause a positive immunoassay result, and you don't know which one it is, right? There are some more specific things like for marijuana, THC, or for cocaine, benzoylecgonine, but many of these are class specific. And if we go back to the opiate example, at high concentrations, say more than 10,000 nanograms per mil, we can get a positive from oxycodone or even from naloxone, which is used to treat the opioid overdose. And so that makes it challenging. The other challenge here is that structurally similar epitopes can be present for completely unrelated compounds. And so in those cases, we really won't know that up front, and we can't do this, determine the cross-reactivity without some additional testing. And so these assays may or may not be useful. It depends really on the clinical or the research question that we have. And so I want to bring a quick example into this. So this is for buprenorphine. If you look on the I had to check. If you look on the left of the screen, that's what a typical mass spectrometry-based pattern is. At the top, you have buprenorphine, and then you have these two metabolites, buprenorphine, glucuronide, and norbuprenorphine. If somebody is taking the buprenorphine, as indicated, you should see all of those analytes, right? Now, the immunoassay doesn't differentiate. It only picks up the buprenorphine and buprenorphine glucuronide primarily, but it doesn't differentiate. Now, if we look on the right-hand side of the screen, those are from an archived methodology. We don't use this one anymore. This is not a high-resolution mass spec, but I put this up here because we get some relative signal between the two. And so there you'll see, this is from a real patient where we see buprenorphine and naloxone. Now, what we don't see is we don't see any of the metabolites. No buprenorphine, glucuronide, no norbuprenorphine. Now, why is this important? Because we know in this population that there is the phenomenon of strip dipping. I don't see any patients, but many of you work with those types of patients. And so you know that this is a real thing where they take the strip and rather than putting it in their mouth, they put it in the urine cup and then they give the urine cup because they know for the immunoassay it will turn it positive. So if we go and look a little bit further into this, what we see there is not only from the mass spectrometry do we, in a single run, we see that we have this buprenorphine and naloxone, we can also see from the relative signal that it's in about close to a 4-to-1 ratio, which happens to be the formulation of Suboxone, right? So we can look at these relative signals and say, well, that's probably, with no metabolites, probably an indication of strip dipping. And also in that same analysis, we then see from the same injection that this person has actually been exposed to cocaine, because we see cocaine and benzoylecgonine. The last thing I would point out is not only would you miss this strip dipping phenomenon, but because when you put there, it can make the naloxone concentration so high, above 6,000 nanograms per mil, that it could actually give you a false positive on the opiate assay that I mentioned in the limitation section. So it really does complicate things when you do an immunoassay. If you have a simple question, that might be useful in screening, but if you have a more complex question, mass spectrometry is something you really need. So if we shift gears then to this idea of high-resolution mass spectrometry, which is the tool that we're using now, the question is, how do we do this, right? And so if we think about our standard mass spectrometry approaches, like I used before, what we're really looking at are selected transitions when we break apart the molecule. And so we would have what we call a precursor ion, or the unbroken molecule, and then we fragment it, and we can look at some of the fragment ions. And in the standard approach, we're sort of switching. We don't see all of the fragments. We typically look for the 2 or 3 most abundant fragments there, and we look at them individually. Sometimes we look at the ratios. But in the high-resolution approach, in this case, we use an Orbitrap mass spectrometer. You could also use a time-of-flight one. But we can see all of the fragments at once. And not only that, what we can do is we couple this with an approach called data-dependent acquisition. What this means is we tell the instrument to keep an eye out for either the 10 most abundant ions in a particular time frame, or we can just tell it, if you see any of these 20 different compounds over the course of your run, then we want you to trigger and break it into fragments. And so by doing this, we can get all of, we call them MS2 spectra, but all that really means is we're looking at just the fragments from a particular precursor ion. Now, the other thing we do with these fragments, now this is a little bit of a text-heavy slide, so if you're a lab person, you certainly can take a look at the text, and that will give you a little more detail on how we do the library matching. I'm going to lean the other way and just talk about this at a really high level. Right, so we can take those fragment spectra that we talked about, or MS2, and what we can do is they just reduce that whole spectra into a single mathematical vector. Okay? And then what the computer algorithm does is it has a reference spectra that it turns into a vector. It takes the experimental spectrum, which it turns into a vector, and it looks at the difference between the vectors. These are in multidimensional space. They look at the size of the angle between the two vectors, and from that they generate a score. This score represents the probability that those two compounds are the same. Okay, and that can be, and it is an empirical score. It can be from 1 to 100 or 10 to 1,000, right? But we're typically looking at this, so a 99 would be a really good match, a 70 might be a marginal match, and a 30 would be a really poor match, not badge. So when we look at this also, the other thing I want to note here for the library matching is that we use different energies to break apart those molecules. And in our reference spectrum, right, that's a public library, that may be a different collision energy used to generate those fragments than what we have in our method. And so sometimes that can result in some mismatches as well. We won't go deep into that this morning, but it's something that's important to keep in mind. So I really want to point is, how do we do the interpretation? So on the right-hand part of your screen, you'll see that's a chromatogram. So that looks as we're separating the sample into its individual components. And for that particular component, we can see what time does it come out. In this case, we're looking at a representative spectrum of benzoylecgonine. That's coming out at about 4 minutes. In the middle panel, we have our internal standard that tells us if we've had any shifts, and then in retention time, and on the left-hand side of your slide is where you have your MS2 or your fragmentation pattern with a library score. So how do we determine what a positive is? Well, the first thing that we look at is we look at the retention time, and we have a tolerance. That tolerance is plus or minus 0.2 minutes. So for 0.2 minutes, if you don't want to do the quick math, that is about 12 seconds in either direction. Okay, so it has to fall in that particular window. Here you'll notice that our expected retention time is 4.03. In this particular patient result, this is a real patient result, blinded, we have an actual result of 4.05, so very close retention time. The second piece we look at is the exact mass within 5 parts per million. So in these high-resolution instruments, we can actually determine the molecular mass, or in the form of a mass-to-charge ratio. We can get that out to about 4 to 6 decimal places. Within 5 parts per million for small molecules, we're really talking that they match out to about the 3rd decimal place. And from there, we can actually get to the molecular formula. We don't know what the structure is necessarily from that, but we do know what the molecular formula would be. And so we get the mass within 5 parts per million. And then the last piece is that we want a library match of 70 or greater for most compounds. There are some certain things, I'm going to use buprenorphine glucuronide as an example, where because of our experimental conditions, the glucuronide falls off, and we don't ever see that. It falls apart in the ion source. And so because of that, we really only see the buprenorphine piece. It matches really well with buprenorphine, but at a different retention time. And so that library match is never the same with that buprenorphine glucuronide. But we look at these 3 pieces, and then as what we're going to tease out as we go through the remainder of the slides are there are going to be some practical considerations where we can't just generate a table of these if they meet these 3 criteria. We have to get our eyeballs on this a little bit. But these are the big things that go into that. So there you see a nice clean peak. This is one of the problems. And that's that, this does meet the criteria, right? We're at the correct retention time. We have a nice, good fragment. We have a nice match. This is probably due to background. Maybe there's contamination in the water, maybe an environmental exposure from touching money or being in the presence of this. And so all of these pieces can come into play. That is literally a pain management physician calling me. I'm sure he has a question about toxicology. So anyway, if we have these low signals, then we have to say, well, this doesn't really meet the criteria. And so we actually have put in place, this is about a 20% noise background. And so that we're going to say that's not really a robust positive, and we would not call that. And so while we want this to be as objective as possible, it's just important to note that there still, at some level, is going to be some subjectivity to this. So we can also use isotope patterns if we have low concentration to sort of sort that out. It's not a primary criteria, but it's a secondary criteria. And so in summary, this is how we make the positive identification. It's via retention time, exact mass, and library score. We do have some visual inspection of peaks, and then we can use isotope patterns when there is a low signal, and that's usually done at the director's discretion. So how do we actually use these, just to sort of close out? So these are real patient samples, and once we implement these new compounds, we see things like fluorofentanyl, and we see this starting to emerge here. Right, we're able to see xylazine. This is not something that's foreign. Now we're seeing this a lot in the HPTN studies as well as clinically, and we're able to see that where we have these good, robust peaks. Now there are a couple of challenges. One thing we see is we can pull this together and look at patterns. So this is from a clinical study in Baltimore, and you see this is 4-ANPP. Now this is a precursor of fentanyl, and when we see this 4-ANPP, we know that there's probably going to be some fentanyl analog, not run-of-the-mill fentanyl, but some sort of substitute fentanyl or fentanyl analog. And indeed, in this subject, we see methoxyacetylfentanyl. Now, one thing I would point out here is that you can get this really information-rich spectrum, because oftentimes, if this peak is kind of small, but methoxyfentanyl is there, it reverts to this peak. And this is, again, why we need to do a visual review. It reverts to this peak. If you were to integrate that peak, you see that's beta-hydroxyfentanyl. So they have very similar spectra, and so we have to make sure, again, for every sample that comes through the lab, we look at every spectra for every drug to make sure that we're integrating the appropriate peak and that we're getting the appropriate library match and it meets the criteria. The last thing we look here is we see tramadol. This is a pain management patient. We see a nice peak. But if you'll see in that library match, there's a secondary peak that is desmethyl venlafaxine. Right? So if you're on a Prestige, a standard antidepressant, you can get a positive signal for that. So in this case, the tramadol was really present, but if you look to the desmethyl venlafaxine, what you'll see is the precursor ion is pretty similar. The most abundant fragment is pretty similar, but with the DMV, or ODV, sorry, you get the 2 fragments that typically aren't going to be present with tramadol. And so you have to make sure that you're taking a look at these things in order to make sure you're calling the right one. In this case, if there was no tramadol present, it would have met the criteria, right? It would be at the right retention time. It would have had the appropriate intensity. It would have had the appropriate library match, but there are some subtle differences there, and so we really have to dig down into that. So just to leave you with these final thoughts, at a really rapid pace here, the use of this high-resolution technology and library matching gives you this really information-rich output, and it does minimize the risk of false positives, but it does not eliminate that risk, right? There has to be an orthogonal confirmatory testing to miss those out. It is very sensitive, so you have to take care to make sure that we don't have any false positives, and this allows us to rapidly expand the menu and look for these emerging drug use patterns in the various populations. And with that, I'm going to close because I know I'm just a bit over, and I'm going to hand this back. I do want to acknowledge these folks in the lab and at Thermo Fisher Scientific, as well as the HPTN funding. And I'll turn it back over to Mark.
All right, fantastic. Thank you, Bill. So our next speaker is Dr. Johan Melendez. He's an assistant professor of infectious disease at Hopkins. And for over 15 years, he's been involved in developing and translating novel molecular approaches for the characterization of pathogens causing STIs, especially those caused by antimicrobial resistant pathogens. His current research combines clinical, behavioral, microbiologic, genomic, and molecular strategies to conduct basic epidemiologic and translational research to identify factors contributing to the emergence and spread of antimicrobial resistance in gonorrhea, and that's what his talk is going to be focused on.
Good morning, everyone. Thank you, Mark, for the introduction, and thank you to the leadership for continuing to think about STIs in the context of HIV prevention. So today I know you've been listening to a lot over the last few days, and you have heard a lot of great data, but what I'm hoping that you will take away from this short talk today will be these 4 key points. Number 1, that we need better diagnostics. We do have a lot in the US, and we are grateful for that, but they are not where we need them, where there is a high prevalence of STIs and HIV. The second point that I would like to get across to you today is that there is really limited data on antimicrobial resistance in STIs. There is a lot of good surveillance programs out there, but again, we need to do more in the setting where it's really needed. The third one is that we need to do a better job at the assessment of AMR in STIs, especially in low and middle income countries. And the last one, and something that I'm going to use to conclude, is this idea that STI research and prevention is actually HIV prevention, that I think everyone in the room will agree with me. So before moving on, I think it's important to talk about where we are in terms of the epidemiology of STIs globally. And so this is data that was published by the WHO recently, looking at the estimated global incidence of STIs. As you can see, globally it's estimated that there is 374 million STIs, and so we are looking at 1 million new cases of STIs every day. Even though trichomonas might be the most common STI, it's not commonly reported because in a lot of communities and countries, it's not a reportable disease. And so you can see that the number of trichomoniasis that you see there is the highest. But in terms of what is being reported right now, chlamydia is the most commonly reported STI, followed by gonorrhea. As I alluded to before, we have a lot of great tests, and most of them can be used at the point of care, especially here in the US. I'm sure most of you are familiar with the Gene Expert, but it takes a little bit longer for that assay to be performed. That in some cases cannot be implemented at the point of care. You're looking at about 90 minutes. Some of the most recent ones that can definitely be used at the point of care include the Binks, the Visby. We also have a rapid test for trichomonas, actually 2 of them that you can see there. And what I wanted to draw the attention to is that all of the tests have really high sensitivity and specificity for detection of these pathogens. But one area where we are really lacking is the fact that all of these tests are really expensive. They require sophisticated instrumentation that cannot be implemented in settings where they're really needed. And so as part of the goal for us at Hopkins, one of the things that we've been trying to do, how do we improve with the technology that we have and develop new technology that can be implemented in the setting where it's needed. And so I'm going to tell you one example, a test that was developed by Hopkins, and we actually tested in Kampala, Uganda, and some of the lessons that we learned from that evaluation of a new STI platform. So here's a test that we developed. It is a small instrument that actually fits in the palm of your hand, and the result can be transmitted to a tablet through Bluetooth. This instrument can be adapted for any pathogen that you would like to use, but in this case, it's a 15-minute assay that can detect Neisseria gonorrhea and also the JARA mutation associated with ciprofloxacin resistance. After the development of this instrument, we took the instrument to Kampala, Uganda, where we conducted a prospective evaluation using penile samples. And we found both great sensitivity and specificity for detection of Neisseria gonorrhea in this community. Some of the highlights that makes this an ideal test for this country is that it's fairly inexpensive. We're looking at about $2 US for the cartridge, and it's portable, and it uses a power bank, so it doesn't require electricity. We can just charge the power bank, and then it can be taken to any community for testing. The other thing that we were able to do with this evaluation was we collected a series of samples that allowed us to find out a little bit more about the epidemiology of STIs in Ugandan men, and you can see here by a paper that was published in 2022. So of the 250 men that we enrolled in this evaluation, 66% of them were positive for gonorrhea. These were men that were symptomatic and were coming to clinics for testing for treatment, because in Uganda there is no testing. 22% were positive for chlamydia, and then you can see a very low rate of trichomoniasis. When we tested Neisseria gonorrhea isolates, we found that 100% of them were resistant to Cipro, penicillin, and tetracycline, which have been traditionally used for the treatment of gonorrhea. Of those men that we tested, 20% of them tested positive for HIV. Most of them were aware of the infection. Surprisingly, 10% of the population, or the group that we tested, were positive for syphilis, and the majority of them were not aware of the infection. The other thing that we did, we looked into Mycoplasma genitalium, which some of you might be familiar, but it's another STI that we are keeping an eye on because the rates are continuing to increase. And this was the first study that was done in Ugandan men, and we found moderate rates of Mycoplasma genitalium, but we also found that some of the samples had evidence of positivity for mycolite resistance. One of the things that was interesting to me was these men that are coming into the clinic with symptoms that often get treated as gonorrhea, some of them actually had Mycoplasma genitalium as the only pathogen, so that is something to keep an eye on. And so the take-home message that I would like to leave you with is that this assessment that we did of using a new point-of-care molecular technology can lead towards understanding STI epidemiology in a setting like this. Now, what else can you do, and what is up and coming when we're looking at non-molecular rapid tests that can be implemented in a low-resource setting is this new assay that was recently published in Lancet. It is a lateral flow assay, meaning that it's testing for antigens for Neisseria gonorrhea. The assay is very simple to use. You take your sample, you put it into a buffer, you load 4 drops of the sample onto a cassette, and 20 minutes later, you can put the cassette into a reader, and then it will tell you whether the individual is positive or negative for Neisseria gonorrhea. And so they evaluated this test in South Africa by collecting samples from men and women in 5 different clinics. And as you can see by the table there was both great sensitivity and specificity in both men and women for detection of Neisseria gonorrhea. What is interesting about the technology is that the reader can be powered by an external body, meaning that it's portable and you can take it to the field to conduct testing for Neisseria gonorrhea. One of the limitations is you can only analyze one sample at a time, but it only takes a few seconds for the reader to be able to read the cassette, so you can run a lot of samples very quickly. And so now I want to shift gears a little bit and talk about the other challenge that we have with STIs, which is antimicrobial resistance, and especially talk about the challenges that we have when we are trying to do this in low and middle income countries. But before talking about LMICs, wanted to briefly remind you about the evolution of AMR in the US. As many of you remember, we were able to treat gonorrhea by using ciprofloxacin in the 80s and the 90s. But by 2007, the CDC had recommended not to use Cipro because the rates continued to increase. Later on in the late 90s, cephalosporins, including cefixime and ceftriaxone, were introduced. But by 2009, we were seeing evidence of the development of AMR to cefixime and also ceftriaxone. Later on, it was recommended by the CDC that instead of using just one antimicrobial, we use a combination of two antimicrobials with two different mechanisms of action, ceftriaxone and azithromycin. But by 2020, the rates of azithromycin resistance had increased so much that the CDC no longer recommend using a dual treatment, and the only recommendation that we have right now is to use ceftriaxone for anyone who has uncomplicated gonorrhea. This recommendation, as you can see by the table here, is used by many countries globally. The only difference is when you look at the concentration of ceftriaxone that is recommended, it varies from 250 milligrams all the way to 1 gram. The other recommendation that is typically used globally is to treat anyone where you cannot rule out chlamydia, to treat them also with Daxi at the same time. And so where are we now in terms of ceftriaxone resistance? This is data from the 2020, looking at resistance from Neisseria gonorrhea isolates that have been reported globally. As you can see, the levels for the most part globally of ceftriaxone resistance are low. We only have about 3 or 4 countries that are reporting greater than 5% resistance to ceftriaxone. But one of the things that is concerning about this map is you look at all those countries that are shaded in gray or white, as you might see here. We don't have any data on AMR, and that is concerning because we really don't know what is going on. This is especially true for Africa, where you can see that data on AMR is only being reported for a few countries. And so in order to find out a little bit about what is going on in Africa, in the evaluation that we did, we looked at those isolates, and as I alluded to before, 100% of them were resistant to Cipro, penicillin, tetracycline. One thing that was that we were very happy was to see that 84% of those men who come into the clinic with symptoms were actually treated with the recommended treatment, which in Uganda is cefixime and doxycycline. But there were challenges to this, especially around antimicrobial stewardship. When we looked at the syndromic case management that they use in Uganda, and we looked at the results that we obtained from all these men for the different STIs, the sensitivity of this management style was really high, but the specificity was very low, and this has to do a lot with the fact that about 68% of these men were treated with metronidazole, even though only 2% of them were positive for trichomoniasis. More concerning is the fact that a lot of these men actually use antibiotic prior to coming to the clinic to receive proper treatment. And you can see there a lot of them obtained the antimicrobials from different places, including those that actually just buy them at the pharmacy or get them from the street. And one of the things that by analyzing the data, we found that those who use antibiotic prior to coming to the clinic had a longer duration of symptoms, even after they were treated with cefixime. So how do we go about assessing antimicrobial resistance? As many of you know, the idea of using culture-based phenotypic antimicrobial susceptibility testing is in decline because we don't have access to a lot of the isolates that are required for susceptibility testing. And so this new idea of using molecular methods to assess AMR is really gaining a lot of traction. And this is looking at targeting what we know to be resistant markers in specific genes that will allow us to identify whether the sample is positive or has a mutation associated with AMR. When we use this approach, this has great sensitivity and specificity if we look at the TET-M gene for tetracycline resistance, if we look at the BLAT-TM plasmid for high-level resistance to penicillin, and then if we look at mutations in the JARA gene specifically, we can conclusively say that the sample has a mutation and that is susceptible or resistant to Cipro. Where we have to be more concerned about is when we start looking at beta-lactams like cephalosporins, because the genes that are associated with AMR not always express that phenotypic, so we need to be concerned about doing this type of AMR analysis by targeting these genes. So I want to spend the next minute talking about the challenges of doing AMR testing in LMIC. So one of the main challenges is the fact that in most countries, syndromic management is used. And so we really don't have any Neisseria gonorrhea isolates, and we cannot do AST. In terms of surveillance programs, there is not too many, so we need to continue working on those. As many of you know in the room, there is limited infrastructure and resources, and then there's also a high cost for antimicrobial susceptibility and quality assurance. On the right, because I'm running out of time, you can see some of the possible solutions that we can have to implement this kind of AMR testing and programs in these settings. A few words about DoxyPrep, because you heard a lot about that throughout the conference. Just wanted to say that the data that we have so far is inconclusive. We don't have a lot of isolates so far to do testing. In some cases, we have high levels of tetracycline resistance. And adherence to DoxyPrep is going to be critical for us to determine whether DoxyPrep is having an effect on AMR. But overall, we need more studies in diverse populations to see what is going on in terms of AMR emergence when we use DoxyPrep. Lastly, to conclude, just quickly going to talk about effect of AMR on STI treatment and prevention. And many of you know that if you have an STI, you are more likely to acquire or transmit HIV. And then you can also see what happens when you have an antimicrobial resistant STI that can lead to treatment failure. And then if you are using DoxyPrep, it can probably decrease protection. In terms of those people, people who are living with HIV, you can see that they're also more likely to acquire antimicrobial resistant pathogens. This is some data just to conclude that from the same study. And I'm just going to quickly move here. What we found from the studies is that in Kampala, there is a high rate of curable STIs, right risk behaviors. And then the take-home message here is that by testing and treating curable STIs, we can identify individuals who are not aware of the HIV status. So some of the takeaways here is that increasing AMR rates are threatening the way we treat gonorrhea, and we need more point of care. There is limited data on AMR, and we also need to do a little bit more research on the effect of DoxyPrep on AMR. And lastly, wanted to conclude by saying that in these trials that you guys are conducting, HIV prevention trials, they can also help to support STI research and also research on AMR. Thank you so much, and to the collaborators and those who fund the work that we do.
All right, thank you very much to all of our speakers. I know we're a little short on time, but I want to provide an opportunity to ask questions, and maybe if we can turn up the lights a little bit. So maybe I can start off. So, Bill, I think, you presented again, sort of a more innovative technology for using library matching and screening. How do you think that could translate to either quantification or confirmatory type testing? Could you comment on that?
Is this good? So one of the challenges with confirmatory testing is we really have to take the ion ratios, and the limitation of the high resolution technology is that it doesn't acquire enough scans to average, so it's kind of a snapshot, and that may skew it because we're not looking at an ion distribution, we're looking at a snapshot in time. And so it really is going to require an orthogonal, like an ion trap or a triple quadrupole type instrument to be able to do that. So I don't think it gets us away from the confirmatory testing. I think we have to take this at face value that it's screening and accept that there are going to be a certain number of false positives and negatives, and then we complement that with other technology.
Sure, no, thank you. I mean, I think that's, sort of the take home that we're seeing is, right, like there's no one magic bullet, and really understanding where all the tools are in the toolbox that could be used in concert to answer a question. And I see that Sten has a question.
Sten Vermund, Yale School of Public Health. I wonder, Sue, directed to you, we have now status neutral HIV care as an increasingly popular strategy where regardless of one's HIV status, one comes in often for ART-based services, either treatment or PrEP. I'm thinking here we have folks who are on antiretrovirals for their HIV positive status, and we have persons who are on CAB-LA. We think they're negative, but in fact they may be positive, and they may be living with HIV without knowing it. Is it reasonable to think of our considerable viral testing capacity that's considerable not only in the US but in Africa and around the world? Could those infrastructures be used to monitor CAB-LA folks until you tell us what the more efficient point of care test would be? Because these are now widely available. What are the pluses and minuses of that kind of way of thinking?
I'm not sure I quite understand the question. So if you have someone on CAB-LA, what are you proposing?
Yeah, you essentially monitor them as if they were living with HIV.
Oh, you monitor them with RNA testing.
You simply use those considerable infrastructures that we have that are being deployed to monitor persons living with HIV.
So I understand now. So
Yeah.
there are pros and cons. For an individual person, it's clear from our prior research that the strategy of screening for infection, including an RNA test, will detect these infections earlier and almost in all cases before resistance emerges. But the downside is that there are clearly false positive results. When you do perform lots and lots of these tests, you will get false positive results. In another setting, that's not a problem. You repeat it and it's negative and you say, oh, it was a spurious result. But in this case, positive results can revert to negative, and this can lead to a whole chain of repeated retesting. And Rafi likes the word consternation for the participant or patient and the provider, because it can be very difficult for months or longer, very difficult to determine an infection can occur. And we heard in the 084 presentation that in cases like this, the provider doesn't have a choice. Do you stop CAB and start treatment, or continue CAB? And there's no right answer, and there's no easy available test that can solve the problem for you. So the RNA tests are not feasible or affordable, everywhere, and they're costly. So given the pros and cons, we have to wait and see how the guidelines develop as we release the information that we got from prospective RNA screening. And as I said, the first of that information from 083 will be presented in July.
Thank you. Sounds like a research emergency.
Great, thank you so much. So I think we have Naranjo and then Wafa.
I don't know if this, okay. Thank you so much to all our presenters. I've got a question for Johan, is it? So maybe I missed this. So normally we have no test for cure for STIs. So do you think that not testing for cure has an impact on antimicrobial resistance, number one? And then number two, where I come from, most of the STIs in women are asymptomatic, and we are treating syndromically, but sometimes we do diagnose them. So do you think also that has an impact on antimicrobial resistance? Thank you.
Thank you for those two great questions. Regarding the first one, I think that we now have recommendations for doing tests of cure for anybody who tests positive for pharyngeal gonorrhea, because we know that the rate of treatment is not very effective in that setting. For general infections, it's not really recommended unless somebody comes back with a repeat infection to see whether or not the treatment worked. In terms of women, I think we need to do more research on that because most of the work that has been done in men because sample collection is a lot easier. But I do think we need to understand the epidemiology a little bit better in terms of what is going on, not only with AMR, but just STI in general, because if we only see men, we know that perhaps for every man that has an infection, there's probably a woman that has an infection. And so we need to continue to monitor that and make sure that we're inclusive of also women in the kind of work that we do.
Great, thank you. And I think what we'll do is adopt sort of the modality of quick question, quick answer. So Wafa, on to you.
Yeah, maybe a quick comment is I think women's self-sampling has been done successfully and it's acceptable. And I think Harriet in Eswatini has done some of this work, but that's not a question. I have a quick question for Bill, actually, is I got a little bit very worried sitting here thinking about all the false positives that are happening in drug screening overall in practice. I mean, do you have a sense of how big of a problem it is? Because it has huge implications for the lives of the people involved in drug treatment programs and so on.
Yeah. No, that's a great question, and that's one that, I'm on the phone with at least one person a week to talk about those results. And I think there are two important things to keep in mind. One is screening confirmatory testing paradigm has to be adhered to, right? So screening testing is optimized for sensitivity, and that means by its nature, it's going to have some false positives, and so you can't do one without the other. I just was on a call with a clinician yesterday morning talking about our cocaine screening is between 1 and 10 nanograms per mil, and confirmatory testing is typically at 100 nanograms per mil to improve the specificity, right? And so, it's important to have these conversations between the lab and the physician. And so I think we have to keep that paradigm in place. And also recognize, a lot of the screening positives are immunoassay based. It doesn't mean you can't have it by mass spectrometry, but I think we have to recognize the limitations. And so we have to find paradigms where we can go direct to mass spectrometry testing for high-risk populations, so a substance-using population, those for which we're distributing controlled substances, and there's a high risk for drug-drug interactions and those types. So in those populations, we should go direct, and we should not order them at the same time. Sorry, last comment, I know it's not quick, but immunoassay and mass spec, if you order them at the same time, you are going to have discrepant results. You will. And then that causes all the consternation from the clinician, and you have to sort of have a rational approach to test ordering. I'll stop there.
Yeah, and I think we see a lot of those parallels when we think about exposure and adherence markers, right? What is exposure and what is actually adherence? And I think that's sort of an undercurrent that we've heard throughout, this HPTN meeting. And then our last question.
Hi, Kayla Kakonda, Peru CTU. My question is for Johan. So just thinking about the context of low and middle income countries where you have concentrated epidemics, and so you have a lot of extragenital infection, and you have syndromic management, which we know does not function, and then also thinking about that with AMR and our lack of testing. We really just don't have tests. So how do we think about all of those pieces together, and what do we do?
Yeah, so one of the main interests for my research is pharyngeal gonorrhea, and we see that there is no testing for pharyngeal gonorrhea, and I think that one of the first things we need to do is reduce the stigma associated with extragenital infections. I think that just understanding them is difficult because collecting an extragenital sample is a challenge. Just asking that question can be difficult. And so just introducing that to the community and making sure that we are letting people know that it's okay to be tested, and spreading the word is probably the first step in doing that. And then the second one, once we understand better the epidemiology of what is going on, because we don't know in a lot of the settings, is really trying to develop tests that can be used and can be applied in that setting for that anatomical site.
Great, thank you. One more round of applause for our speakers. And very, very importantly, there is no break, so we will call up Mike and Wafa. So thanks.
Okay, great. Thank you very much. And now we get to the fun part of this annual meeting. I think firstly, it's wonderful to hear of all the innovations that are happening in the laboratory and that are building on our science and our research. So I think there's a slide coming up somehow. Is there a slide? Okay. I think many of you realize maybe in this room have participated in HPTN 091. And that study has been completed, and actually yesterday or the day before was maybe the last meeting of the team face-to-face. I'd like to acknowledge the leadership of HPTN 091. Hopefully they're in the room. Tonya Petit and Sari Reisner, are you here somewhere? Yes, great. This was not an easy study to design or implement. I always say this is the very first study that's by the networks, any of the HIV networks that exclusively focus on the recruitment, and that was conducted amongst transgender women in this country and in Latin America. And I have to applaud the leadership of the team for navigating and guiding all of the sites that participated in this study from the very beginning until this conclusion of the study. I also want to acknowledge the teams at the sites that participated in 091. If stand up, anybody in the room who participated in 091, please. Okay. There was a wonderful session just the day before yesterday where there was a lot of sharing of experiences and lessons learned, and it was very palpable, the passion that these sites had and the teams had to do the study and to make it such a success. And many of the sites said, all of them said, now they're positioned, they know how to work with this population and successfully, and I think this bodes very well for what comes next in terms of addressing HIV amongst transgender women in the United States and around the world. So congratulations again to the amazing team, and thank you for your commitment and to doing this study and doing it so well. Okay, great. Next slide. Okay, we also want to congratulate the teams that played an incredible role in getting HPTN 094. I have to say, another very difficult study, very complicated study. You know, this is a study that's focused on testing an integrated strategy of delivering multiple interventions on a mobile van versus a static in a static context at a facility. And again, focusing on a population that we're very proud in the HPTN that we have been focusing on as a very specific population of people who inject drugs or people who use drugs. Again, the teams have really had to navigate a lot of complexities, as you can imagine, just getting the vans to be recognized as a research site. And I have to thank NIH and Carl and Cheryl and others, Lydia's sitting here in front of me, but many others who who supported us in making this happen, and we await the results of the study. But it's really looking and testing a very novel intervention in terms of delivering a package of HIV prevention, but also delivery of medications for opioid use and so on in the community versus in static facilities. The leadership of the team also worked so hard, and that's Steve Shoptaw and Nabila Al-Bassel. Neither of them are here because they're at another conference in Montreal that's focusing on substance use, but want to acknowledge their amazing commitment to getting the study done, as well as the teams also in the various sites. Again, a very complicated study to conduct, and I can tell you this from firsthand experience. 091 was done at the Harlem site and 094 at the Bronx site in New York, and I heard daily of the challenges that the teams were overcoming and problem solving. So 094, anyone in the room who participated, thank you, amazing work. And I think the lessons learned from 094 are going to be incredibly useful as well as we move forward with 103, another study in people who inject drugs. So we have now the experience and the expertise to work effectively and do high quality, rigorous research in these populations. So congratulations and thank you to these teams. Okay, next slide. Now we have the Distinguished Service Award, and this is kind of the HPTN Lifetime Achievement Award, okay? And we are very pleased to acknowledge the recipient of the Distinguished Lifetime Achievement Award. Next slide. Linda Emmel.
Do you have the award cake slides next? Is that what we're doing?
Mm-hmm.
Is that next? And then, okay.
Hey, Linda. Now, Linda is beloved by everyone in this room. I mean, it's just that she's touched everything we do and everywhere. And just to give you a little bit of a sense of her trajectory, she's currently the HPTN SDMC Associate Director. She's been a staff scientist. She's a member of the HPTN Policy and Procedures Group since 2005. She's a member of the Executive Committee, a member of the Evaluation Committee. I mean, it's just unbelievable. It's just literally unbelievable. And this morning, we're at breakfast, and I realized that she has a repository of every single study we have ever done right there in her head. So I was inspiring her that now she's threatening to retire. It hasn't sunk in yet, Linda. She's threatening to retire. I was trying to inspire her to write a book, the expose of what happens in HIV prevention research. But Linda, I cannot tell you how much we treasure you, we cherish you, and all your many, many, many contributions in so many dimensions of the work of the HPTN for so many years. You've been just an amazing, you're a gem. And that's what I can say. Thank you. There is an award that's going to come to you. We're not sure where it is, but I think there's something that's going to definitely come to you that you can enjoy as you contemplate your next steps. So thank you so much for. Oh, Eric is running over.
Top performers are for the.
There's something here for. Something here for Linda. Oh my God.
Who would know?
Linda, Linda. What would we do without,
Yeah,
without
thank you,
Eric?
Thank you.
Come. Let's come on up, please.
Congratulations. Yeah.
Why don't you stand in the middle here?
There's
And we
probably
need a
some, yeah.
picture.
Linda,
And you have to hold this.
We surprised
You have to hold this.
You were surprised. Well deserved.
Thank you.
Well deserved.
Great, thank you.
Thank you.
Okay, and I hand it over to Mike for the next award.
Next slide, please. Okay. I'm not sure. Ward Cates literally, there's some people who are inspirational beyond kind of imagination and creative and funny and beloved, and Ward Cates is one of those bigger than life human beings. And Ward died several years ago, and we, in his honor, started the Ward Cates Spirit Award. He also really, as I recall, started the network. It wasn't the PTN, had another name, and just an inspirational leader and really a best friend. He was born in New York in 1942. He was, as I said, athletic, charming, and funny. He played tennis. Married 50 years to his wife, Joan, 2 daughters, Sarah and Deborah, and 4 grandchildren who each have interesting stories that I won't go into. Ward was a remarkable champion of public health. He was the director of STD research at CDC for many years, but before that worked on he would be terribly troubled in our time right now because he worked on post-Roe v. Wade benefits, which he demonstrated in literally 100 articles in 2 years that showed that after Roe v. Wade came in, women's health improved so dramatically it was statistically off every known chart. And just a remarkable series of articles, which did not make him very popular in the Reagan administration, by the way, his literature. He worked for Family Health from 94 to 2016 in many different roles, was president for many years. He co-authored 450 publications, and he was just a very famous and big leader. And his this award is based on his personality, which is his commitment to leadership in public health and health as a right, both internationally and domestically. He was very rigorous. He was actually remarkably astute at article review and really rigorous scientific excellence. He was probably the most generous person in the history of the world. My daughter, who was like a 14-year-old girl, worked for him. So it's just generous person, tremendous integrity, honesty, loyalty, very compassionate person, and valiant in every possible way. And those who knew him are all smiling because they remember his big, hey guys, and his personality. And this is a picture award, this much beloved character. So we have this award, and the award's gone to exceptional people. I won't name all of them, you know. One of them is sitting right there, the very handsome Ken Mayer. And Sten, Croatia, our friend James, our late friend James, Tom Fleming, Beatrice, who is probably still in the room, Kathy Hinson, and Rafi, who now replaces us. But who will get the award this year? Well, this is a special event. This year it's going to be Steve Shoptaw. And Steve is a professor at UCLA, and we feel Steve has been tireless. He's got all the qualities that I've already established, but he's also been tireless in his contributions to people who inject, to substance abuse in general, especially people who inject drugs. And just it's pushing a boulder up a hill, and he just never stops pushing that boulder up a hill. So we're very proud of him and his recognition through this award. Now, unfortunately, he's at the meeting we talked about with Nabila for the international or national NIDA meeting, or I don't know what they call it since we don't, somebody knows.
But we have
BCVD? It sounds like one of our meetings. Anyhow, he's at the, well, we have a video of Steve surprisingly receiving this award. So who's got the video?
Unfortunately, I can't be there today. I would love to be there with you, but I'm in Montreal at the College on Problems of Drug Dependence. I am the awardee for the Ward Cates Award, and it makes me kind of like you could knock me over with a feather. I'm deeply humbled to be thought of in the same breath as Ward Cates, and I'm super grateful to Waka, Mike, Mew, and the selection committee for naming me this. I also want to point out that there's some wonderful things that I've learned over the years. A lot is happening at this intersectional work between addiction medicine and infectious diseases. And these scientific advancements make me think about a challenge from John and Merlin at last year's annual convention, asking what is the agenda for reaching the 10 to 15% of people who are unable I would propose a humble solution, and that is to focus more energy and resource at the intersection of the areas of infectious diseases and addiction medicine. Among people who inject drugs, there are HIV risks that happen when people become dependent on opioids or other drugs that are related to legal risks. We also know that the majority of infections and the majority of things that happen to interfere with remain virally suppressed for people who use drugs really don't have anything to do with needles, but have to do with sexual behaviors or even the direct interactions of some of these drugs with HIV transmission dynamics. So what I think we really need to think about, and I would call us to working more diligently about, is adopting whole person strategy that emphasize integrated care using one-stop shops. Not only do we have an issue with this intersectional science, but we also have the problem of across the world, we can't get there from here. So thinking about breaking down silos so that care can be delivered in an organized, integrated strategy makes a lot of sense to me. I want to close my remarks today by saying again just how grateful I am to Watha, Mike, and Mira, the folks at FHI 360, the folks I've met at Oxford. I will point out that Jane Buck was the first person who said, "Hey, Steve, I think that clinic over on Vine Street might have legs with an HPTN." So a shout out to Jane wherever you are. Of course, I've made so many colleagues and friends that I can't go through and name them all. But thanks again for this award. Again, I wish I was there with you. And a big hug, and I raise a glass. Thanks very much.
So thank you, Steve, in absentia. Before we go on, let me just make the point. Make the following point. First, let's thank FHI 360 for the organization of this meeting, for all the LOC leadership, especially Niru, Ayana, Estelle, and others. They did a terrific job. Many people think this was our best meeting ever. This is for Carl. And so I really let's have a round of applause for Elsie, not Estelle. Estelle's on my mind, but Elsie. I was thinking Elsie, but Elsie organizes this meeting with the help of Niru and all the communications team. And who else, Wafa? Who else? We thank everyone for getting us this far because we're coming to the end. Now, this particular year, because of COVID and everything else, awards are a little bit different. The sites didn't have that many things going on like that, so we have a little different presentation of the awards. We have a top performer award, and we're going to have Linda Emmel give the first, who just received her own award. How circular.
Hello, folks. So I would like to, or I have the honor of announcing the Site Data Management Excellence Awards for this year. The first is Seke South CRS and the Milton Park CRS in Zimbabwe. These data management excellence sites are ones who have submitted thousands of case report forms, and you can imagine it's for 084 and plus antibody studies, I believe, also, and have met all of the data management standards that we set for, well, we didn't have accrual or retention really this year, but for certainly timely submission of data and for responding to their queries on time, for getting those AE CRFs in on time. We at Sharp depend on you to submit things on time and as accurately as possible so that we can report out to the protocol teams and the safety people and give them the accurate reports that they rely on. So thank you so much to Seke South and to Milton Park.
Something will be forth. The award itself will be forthcoming in the mail.
Yes, we will be. Yes, your award's in the mail.
Is anyone here from Harare? Oh, stand up, please.
Come on. Yeah, stand up, please.
Yay! The award's in the mail. Thank you, Linda. Okay, so Estelle, where are you? Okay. Estelle will now replace Linda. And, thank you, Estelle. Here you go. Oops. Okay. Yeah, just forward.
Linda? There was a runner-up, hold on.
Uh-oh. Back Linda. See how organized we are?
I thought we had a runner-up. Okay, the runner-up for the Data Management Excellence Award this year is the San Miguel CRS in Lima, Peru. They submitted over 4,000 pages of data and met all of the standards. So this was for 083 and additional
Do
studies.
it after the. All right. Is anyone here from outside? Did they stand up? Stand up.
Anybody from this,
Anyone from Lima?
no.
Okay. And we're going to take a picture after this with our colleagues from Harare, so don't leave.
Thank you very much.
Okay, Estelle.
Linda? Yes. Don't go down, we've got another one.
We love our data managers.
All right.
Okay, I would like to also thank the CITBM site in Lima, Peru, this is another honorable mention. They submitted this in the past year 2,000 pages of data and met all of the standards.
All right. We know they're not here. No one's here. Okay.
Anyone here
Anyone
from the
here?
site?
That's-
Anybody, I'm assuming that nobody, or are they? Oh, yay!
Tell them the awards in the mail.
Yes,
The awards
the award's in the mail.
All right, Estelle.
Now, are we done? Yes.
Yeah.
Yes.
All right, okay, time for laboratory management.
Hi, everyone. How do we go back? Okay. All right. I'm here for the Laboratory Management Excellence Award. The first award is for top performers. We had 2 labs that had perfect laboratory audits. There were no lab audit findings. So the first was the Raihes site in Chiang Mai, Thailand, and the other site is Eswatini. And can those people stand up at least?
Do they get these?
No. Oh, no.
Where's Eric?
Yeah, there they are. Okay.
All right, you sure? I'm sure. All right, then the awards in the mail, maybe.
Yeah, awards in the mail. And we have one more award, that is for perfect shipments to the LC, and 100% lab data queries were addressed within 7 days, and that top performer is the George Washington University CRS site. And I don't know if someone's here from that site.
Anybody here?
Doesn't look like it.
Okay, all right.
And I think you have one more.
One
You-
more.
You.
Yeah, okay. And the last comments. One is that our Siloam CDC site, CDC is no longer going to maintain that site. We want to thank, I don't think anyone's here from that site because CDC is ending that site. We want to thank the Siloam, Thailand site they were really a great site for all the many years they participated in all our studies. Let's have a round of applause for them. And I hope our friends from Chiang Mai will tell them that we thank them at this meeting. And then, I believe on behalf of Wafa and I that we are done. There's no more slides. There's no more talks. There's nothing but lunch outside. We want to thank all of you for being here for these days. We think it was a terrific meeting. Served all the purposes we could possibly enjoy. And we will see you next year. So safe travels, and thank you once again. Let's have a round of applause for yourselves.